Welcome back to the deep dive. Today we are shifting gears in a major way. Usually we take a broad topic, something like, I don't know, the history of coffee or the mechanics of black holes, and we widen the lens. But today...
We're going vertical.
Today we are going vertical. We are drilling down into what I like to call the heavy hitters of the medical canon.
The books that physically weigh down your backpack.
Yes.
The ones that give you back problems during medical school.
Exactly. And we are starting with the absolute juggernaut. If you have ever set foot in a surgical ward or even, walked past a medical library, you know this book.
Oh, yeah.
It is the Bible of surgery, Baily and Love's Short Practice of Surgery. Specifically, we are looking at the 28th edition.
It is a classic. It's one of those texts that has been around so long, since 1932, I think, that it feels like it was carved on stone tablets.
Right.
But the 28th edition actually has some massive updates that fundamentally change how we practice surgery today.
And that is our mission today. We aren't trying to read the phone book to you. We are taking just one specific chapter, Chapter 53, Oral Cavity Cancer, and we are going to deconstruct it.
Break it down.
We want to understand the nuts and bolts of how a surgeon thinks when they look into someone's mouth.
And I do want to make a very important disclaimer right at the start.
Please.
We are going deep, but this is an interpretation. We are highlighting the critical concepts, the high-yield stuff, as students like to say. This is a ready reckoner.
Yes.
It is absolutely not a replacement for reading the chapter.
Right. Do not throw away your textbook. Think of this as the audio guide you listen to while walking through the museum.
That's a good way to put it.
It helps you understand what you're looking at, so when you do sit down and read the text, the concepts stick. It's a revision aid.
We want you to visualize the anatomy, the pathology, and the surgery. Keep the book handy for the diagrams, especially, and I mean especially, when we get to the reconstruction flaps later.
Oh, yeah.
But use this time to get the narrative straight in your head.
So here is the roadmap. We have about 40 minutes or so. We are going to start with the geography, the anatomy of the battlefield.
The lay of the land.
Then we'll look at the enemy, the risk factors, and the epidemiology. We'll break down the rules of engagement, which is the staging, and, trust me, the 28th edition threw a massive wrench in the works there.
A huge one.
And finally, the battle plans, how we cut it out and how we put the patient back together.
And my job is to keep us focused on the why. I mean, memorizing T&M staging is just, it's boring.
It is.
Understanding why a tumor is staged a certain way because of how it kills the patient, that is what makes you a clinician.
Okay, let's do it. Let's start with the lay of the land, the geography. Chapter 53 is titled Oral Cavity Cancer. Now, to a layperson or even a first-year student, the oral cavity is just the mouth.
Right, the whole thing.
But in head and neck surgery, boundaries are everything.
It is a game of millimeters. You have to define the territory strictly because the cancer behaves differently depending on which side of the line it starts on.
So help us draw the line. Where does the oral cavity officially end?
The textbook definition, and this is a classic exam question, by the way, is that the oral cavity extends from the mucosal surface of the lips back to the junction of the hard and soft palate, so the roof of your mouth where the hard, bony part meets the soft, fleshy part.
Okay, that sounds simple, but let's stress test it. If I open my mouth and say, and you see a tumor on my tonsils, is that oral cavity?
It is not. That is the classic trap. The tonsils, the soft palate, the base of the tongue, and the posterior pharyngeal wall. That is all oropharynx.
The uvula, that little dangly thing?
Oropharynx. Different chapter, different disease.
So why does this distinction matter so much? Is it just, pedantic, anatomical labeling?
Oh, it's vital. I mean, the biology is completely different. Oropharyngeal cancer, the throat stuff, is increasingly driven by viruses.
HPV.
And it responds really well to radiation. Oral cavity cancer, the front of the mouth, is a different beast. It's usually lifestyle-driven, it's aggressive, and it almost always needs surgery. If you mix them up, you mistreat the patient. Simple as that.
I like to use a house metaphor here. Think of the oral cavity as the foyer, or the front porch of the house.
I like that.
It's the entry point. The oropharynx is the hallway leading back into the house.
That works perfectly. And the rules in the foyer are different from the rules in the hallway.
So for today, we are strictly in the foyer. We are talking about the lips, the alveolar ridges.
Which is the gums.
The gums, the floor of the mouth, the hard palate, the buccal mucosa.
The cheek lining?
The cheek lining and the anterior 2/3 of the tongue.
Correct. The mobile tongue, the part you can stick out at someone, the base of the tongue, the part that anchors you to the throat, that's the hallway. That's oropharynx.
Okay, map established. Now let's look at the numbers. How big of a problem is this globally?
It's significant. It is the 8th most common cancer globally. We're looking at roughly 350,000 new cases every single year.
And historically, this has been a men's club disease, right?
Unfortunately, yes. The ratio used to be heavily skewed, something like 2-to-1 men to women.
And that's not genetic.
No, it's behavioral. Men were historically the ones smoking the unfiltered cigarettes and drinking the hard liquor. But that gap is narrowing.
As lifestyle habits equalize, so does the cancer risk. Now, looking at the map of the world, this isn't spread like butter on toast, it's clumpy. There are hotspots.
Very distinct hotspots. About 2/3 of these cases are in low to middle income countries. Southeast Asia is the epicenter.
Right.
India alone accounts for nearly 1/3 of the global burden, around 100,000 cases a year.
That is a staggering concentration. One country carrying 1/3 of the global load.
It is, but you also see high rates in places like Papua New Guinea and surprisingly parts of Europe.
Like where?
Hungary and France have historically high rates, again, tracking with cultural consumption of alcohol and tobacco.
There was one statistic in the chapter that really pulled me up short. We talk about all this modern tech robotic surgery, immunotherapy, 3D reconstruction, but the survival rates, they aren't exactly skyrocketing.
It's the sobering reality of this field. Despite all our advances in understanding the genome and refining our scalpels, the overall 5-year survival rate globally is stuck.
Stuck at what?
Around 50%. Flip a coin. And in high-burden areas like India, it's reported as low as 35%.
Wow. That really drives home why we are doing this deep dive. If we can't cure it late, we have to catch it early. Which brings us to the usual suspects, the risk factors.
The big three: tobacco, alcohol, and betel quid.
Let's talk about the synergy between tobacco and alcohol. Because most people know they are bad individually, but together they are worse than the sum of their parts.
It's a force multiplier. Think about it this way. Alcohol acts as a solvent.
A solvent?
It dehydrates the mucosa, the lining of the mouth, and makes the cell walls more permeable.
It effectively strips the paint off the wall.
Exactly. It weakens a barrier. So when you take a drag of a cigarette, the carcinogens from the smoke can penetrate much deeper into the tissue because the alcohol has opened the door for them.
That is a terrifying image. The alcohol unlocks the door and holds it open for the smoke.
Precisely. That's why the risk isn't additive. It's multiplicative. It's a nasty combination.
But I want to spend a minute on betel quid, because if you are practicing in the West, you might miss this, but globally, it's the main driver. This isn't just chewing tobacco.
No. This is often called pan or gutka. It's a cultural habit in South Asia and parts of the Pacific. It's a mixture.
What's in there?
You have the areca nut, which is carcinogenic on its own, usually mixed with slaked lime, catechu, and spices, wrapped in a betel leaf.
And the placement matters, right? The chapter was very specific about this.
It does. In the West, where people smoke, the smoke swirls around the whole mouth, but often hits the tongue or floor of mouth hardest.
Okay.
With betel quid, users tuck the packet into their cheek, into the buccal sulcus, often leaving it there for hours, sometimes sleeping with it.
So you have a carcinogen resting against the mucosa for hours at a time, day after day.
Exactly. So in India, we see a massive disproportion of buccal gingival cancer of the cheek and gum right where the packet sits. The cancer literally grows in the footprint of the habit.
It's direct contact carcinogenesis.
That's the one.
Now, we have to address the elephant in the room regarding viruses, HPV. Everyone is talking about HPV and throat cancer. Michael Douglas, all of that. Let's clear this up. Does HPV cause oral cavity cancer?
This is a crucial concept alert. If you are a student, highlight this in your mind. We know HPV is a major driver for the oropharynx.
The hallway.
The tonsils and base of tongue, exactly.
Yeah.
In some Western countries, 70% of tonsil cancers are HPV positive.
But we aren't talking about tonsils today. We are in the foyer.
Exactly. In the oral cavity, the foyer HPV is a minor player. It accounts for maybe 5% of cases.
That is a massive difference, 70% versus 5%.
But it matters for prognosis. In the throat, HPV-positive cancer responds beautifully to treatment. Patients do very well. Yeah. In the mouth, even if you find HPV, it doesn't seem to give that same survival benefit. So oral cavity cancer is still an environmental disease: smoke, drink, and chew.
So let's check in. If a patient walks in with a tonsil tumor, you're thinking virus.
Almost certainly, yes.
If they walk in with a tongue ulcer, you're thinking tobacco or betel nut.
Broadly speaking, yes. That is the safe bet.
Okay, that's clear. Let's move to section 2, the warning signs. Because usually the cancer doesn't just appear overnight. There is smoke before the fire.
We call these potentially malignant lesions, and if you want to spot them, you need to know your color palette.
I love a good color-coded system. Let's start with white.
Leukoplakia. The definition here is practically useful. A white patch or plaque that cannot be rubbed off and cannot be characterized as any other disease.
Cannot be rubbed off. That's the bedside test. If I see a white patch and I scrape it with a tongue depressor and it comes off,
it's probably candidiasis thrush, fungal, not cancer. If it stays put, it's leukoplakia.
And how worried should we be about a white patch?
It's a spectrum. I mean, a huge spectrum. The risk of that patch turning into cancer ranges from 0.13% all the way up to 34%. It depends on the pathology and the subtype.
Okay, so white is caution. What about red?
Erythroplakia. These are bright red, velvety plaques.
Anchor for memory. Red means danger.
Absolutely. Erythroplakia is much rarer than the white patches, but it is far more dangerous. The transformation rates are significantly higher. If you see red, velvety tissue that shouldn't be there, your alarm bell should be ringing loudly.
Yeah, if you mix them, like a speckled egg.
Erythroleukoplakia, a mix of red and white. This carries the highest risk of all the common lesions. That speckled appearance is a sign of chaotic cell growth. It's a very bad sign.
Are there other specific conditions? I saw PVL mentioned in the chapter.
Yes. Proliferative verrucous leukoplakia. This is a nasty one. It's aggressive, it spreads, and it has a very high rate of turning into cancer. It often comes back even after you cut it out.
And then there's oral submucous fibrosis. This one sounded horrific to me.
It is a debilitating condition. It's linked almost exclusively to areca nut chewing.
From the beetle quid.
Exactly.
Yeah.
It causes the lining of the mouth to become rigid and white. The patients literally cannot open their mouths. We call that trismus, because the cheek lining turns into leather.
And that leather is prone to becoming cancer.
It is a very high-risk state, yes.
So if I'm a student in a clinic and I see a patch, is there a checklist to determine if this specific patient is high risk?
Baily and Love gives us a high-risk list, and paradoxically, one of the factors is being a non-smoker.
Wait, pause. Being a non-smoker makes the lesion more dangerous. That sounds completely backward.
It does, doesn't it? But think about the logic. If a heavy smoker develops a white patch, it's a reaction to the smoke. It's a defensive callus. If they stop smoking, it might go away.
Okay, that makes sense. It's an environmental reaction.
But if a non-smoker develops a dysplastic lesion without any external irritation, it suggests their own biology, their genetics, is unstable. The cells are misbehaving on their own. That is inherently more worrying because you can't just remove the irritant.
That is a fascinating insight. It's like a fire starting without a match.
Exactly. Also, look at the size. Anything bigger than 200 square millimeters is bad. And location, the lateral border of the tongue and the floor of the mouth, are the high rent districts for cancer transformation.
Now, here's a depressing thought. Let's say we see a white patch. We cut it out. Is the patient safe? Done.
You would hope so, but often, no. This brings us to the concept of field cancerization.
I've heard this described as condemned mucosa.
It's a dramatic term, but it's accurate. Imagine a carpet that has been stained by wine. You can cut out the darkest spot, but the wine has soaked into the fibers of the whole rug.
Okay.
The entire lining of the mouth has been bathed in tobacco and alcohol for 20 years. Even if you remove the visible lesion, the surrounding cells are genetically damaged. They're already on the path.
So the field is primed for cancer.
Yes. That's why these patients need surveillance for life. Cutting out the patch treats the lesion, but it doesn't cure the field.
Let's move on to section 3, the blueprint of the enemy. We've done the biopsy. We have the pathology report. What are we looking at?
95% of the time, it is squamous cell carcinoma, or SCC. It arises from the squamous lining of the mouth.
And we grade it. Well, moderate, poorly differentiated. That just means how much it still looks like skin, right?
Yes. Well differentiated looks like organized skin cells. Poorly differentiated looks like a riot, just anarchic cells that have lost their identity.
But the real meat of this chapter, and the thing that listeners really need to pay attention to, is the staging. We are talking about the TNM 8th edition.
This is the game changer. If you learned staging 5 or 10 years ago, you need to wipe the slate clean.
Wow.
The 8th edition introduced a massive shift in T-staging involving DOI, or depth of invasion.
Okay, let's unpack this. Depth of invasion versus tumor thickness. To a layman, those sound like synonyms.
They're not. Think of the iceberg effect. In the old days, we measured tumor thickness. literally from the very top of the tumor bumped down to the bottom.
Okay, so the whole height of the iceberg.
Exactly. But imagine a tumor that grows outward, like a mushroom or a cauliflower. It might be 2 centimeters thick, but it's sitting on top of the skin. It's not digging in.
So it looks big, but it's superficial.
Exactly. The new metric, depth of invasion, DOI, measures from the horizon of the basement membrane, where the normal tissue surface should be, down to the deepest point of the tumor roots.
So it ignores the mushroom cap. It only cares about how deep the roots are digging into the soil.
Precisely. Because the roots are what kill. Deep invasion accesses lymph channels and blood vessels. That's how the cancer escapes.
And how does this change the staging number, the T stage?
Drastically. A small tumor on the surface, say 1 centimeter wide, used to be a T1, easy fix.
Right.
But if that small tumor has roots deeper than 10 millimeters,
It gets upstaged.
it jumps all the way to T3. A small surface tumor can be a T3 stage just because of DOI. That means a more aggressive surgery and likely radiation.
That is a radical shift. It forces us to respect the vertical growth, not just the horizontal width.
It aligns the staging with the survival reality, which is what staging should do.
That's the T stage. What about the N stage, the nodes? What's the new buzzword there?
ENE, extranodal extension.
Sounds ominous.
It is the single most important prognostic factor we have. Full stop. Normally, a lymph node has a capsule, a shell. If the cancer spreads to the node but stays inside the shell, that's bad, but manageable.
Contained.
But if the cancer grows so aggressively that it bursts out of the lymph node capsule and spills into the surrounding fat and muscle of the neck, that is ENE.
It's a prison break.
Exactly. And the consequences are severe. The presence of ENE automatically upstages the nodal disease.
Right.
And clinically, it cuts the survival rate by 50%.
50%, just because it broke the capsule.
Yes, it indicates a biologically aggressive tumor that does not respect boundaries. It's a game changer for treatment.
So let's do a quick check-in question for our listeners. Rewind this if you need to. If you are reading a pathology report and you see DOI 12 millimeter and ENE positive, what does that tell you instantly?
It tells you that you are dealing with a T3 tumor, because DOI is 10 millimeters, and high-risk nodal disease. This patient is in trouble and needs maximum therapy.
Got it. Let's move to section 4, the detective work, diagnosis. I want to create a fictional patient to make this real. Let's call him Mr. Gupta. He's 60 years old.
Okay, Mr. Gupta. Let's say he has a history of chewing betel nut for 20 years. He comes into your clinic pointing to an ulcer on the side of his tongue.
Okay.
He says it's been there for 3 weeks, and crucially, it doesn't hurt much.
Painless is a key word there, right? We often assume cancer hurts, but early on, it's silent.
The silence is what causes the delay. So you look in his mouth. What are the cardinal signs? What are you looking for?
I'm looking for an ulcer with rolled edges, like a crater with a raised rim.
Good. And you have to put gloves on and feel it. You cannot diagnose oral cancer with your eyes alone. You need to palpate.
Induration.
Yeah.
That's the word.
Hardness. It shouldn't feel soft like normal tongue muscle. It feels firm, almost woody. And you use 2 hands by manual palpation. 1 finger inside the mouth, 1 hand under the jaw. You want to feel the thickness. You want to feel that DOI.
What if Mr. Gupta tells you his ear hurts, but his ear looks fine?
That is referred otalgia. The sensory nerves of the tongue and the ear are connected. If his ear hurts, it means the cancer is infiltrating the nerve deep in the tongue. That is a late bad sign.
Or if he can't open his mouth very wide?
Trismus. That means the cancer has spread back into the muscles of mastication, the pterygoids. He literally can't unlock his jaw. Also a very bad sign.
So we are suspicious. We need tissue. What is the golden rule for biopsy?
Incisional biopsy. We take a scalpel and we take a slice. We do not just scrape it with a brush.
And we don't use one of those little hole punch biopsy tools.
You can, but a scalpel allows you to control the shape. You want to narrow and deep. You need to catch the interface between the tumor and the normal tissue. And stay away from the center if it looks white and dead.
Because necrotic tissue, dead tissue, tells no tale.
Exactly. The pathologist will just tell you it's dead junk. You need live cells from the active invading edge.
Now, Mr. Gupta also has a lump in his neck. How do we biopsy that? Do we cut into it?
No, absolutely not. This is a critical error. Never do an open biopsy on a neck node if you suspect cancer.
Why not?
If you cut into it, you spill cancer cells into the neck planes, you disrupt the lymph drainage, you ruin the chance for a clean surgery later. It makes a curative surgery much, much harder.
So what do we do?
FNAC, fine needle aspiration cytology. A tiny needle, usually guided by ultrasound. You suck out a few cells. It's safe and highly accurate.
First line for the neck is the needle. First line for the mouth is the scalpel.
You got it.
Let's talk imaging. Mr. Gupta needs scans, CT or MRI.
Depends what you're looking for. If we are worried the tumor is eating into the jawbone, we need a CT scan. Bone loves CT. It shows cortical erosion beautifully.
But for the tongue itself, to see that depth of invasion we talked about?
MRI is the king of soft tissue. It gives you high-definition contrast of the tongue muscles. It tells you the tumor's crossing the midline or wrapping around the lingual artery. Both are critical for surgical planning.
Before we leave diagnosis, I want to touch on SLNB sentinel lymph node biopsy. We hear about this constantly in breast cancer and melanoma. Are we doing this for mouth cancer?
We are, but for a specific group. Early-stage tumors, T1 or T2, where the neck feels clean and the scans look clean. We call that CN0, clinical N0.
So instead of stripping out all the lymph nodes in a big surgery, we just find the first one, the sentinel, and check it.
Exactly. We inject a radioactive tracer around the tumor. It drains to the first guard node. We find that node with a probe, take just that one out, and if it's clean, you spare the patient a big neck dissection.
Okay.
If it's dirty, you proceed to the full surgery. It's about de-escalating treatment where it's safe.
All right, Mr. Gupta is diagnosed. T3N1. Now we move to Section 5, the battle plan, surgical management.
The core principle here is simple. Surgery is the mainstay. In other cancers, we might lead with chemo or radiation. In the oral cavity, we want cold steel. We want to cut it out.
The first problem is access. The mouth is a small cave. How do we get to a tumor at the back of the tongue?
If it's small and at the front, we go transoral through the open mouth. But if it's big or way in the back, we need to create room.
This is where we get the lip split mandibulotomy, which sounds intense.
It sounds aggressive, and frankly, it looks dramatic. We literally split the lower lip right down the chin and cut through the jawbone, the mandible, with a saw. Then we swing the jaw open like a gate.
It's like opening a service door to reveal the backyard.
Exactly. It gives you unparalleled access to the back of the mouth. Then at the end, we plate the bone back together with titanium.
What about for tumors in the upper jaw, the maxilla?
The Weber-Ferguson incision. It goes along the side of the nose and through the lip. It creates a flap of cheek skin you can lift up like the hood of a car.
Okay, we are in. Now we resect. What are the margins? How far from the tumor do you cut?
We aim for a 1 centimeter clinical margin. That means we want to cut 1 centimeter away from where we think the tumor ends, all the way around in 3D space.
Now, the mandible dilemma. This is a big decision point in the OR. The tumor is touching the jaw. Do we cut the bone or not?
It depends on the invasion. If the tumor is just abutting the bone or stuck to the lining, the periosteum, we might do a rim resection.
That's like shaving the top off the bone, right? You're not breaking the jaw in two.
Yes. You keep the structural arch of the jaw intact. The patient keeps their chin contour.
But if the tumor has invaded into the marrow space, the spongy inside of the bone?
Then you have no choice. You have to do a segmental resection. You take out a full cylinder of bone. The jaw is now in 2 pieces.
And that creates a massive reconstructive challenge. You can't just leave a floating jaw.
No, you cannot. That's a huge problem.
One last thing on the surgery managing the neck. Let's say Mr. Gupta's tumor is on the tongue, but his neck scans were clear. Do we leave the neck alone?
This used to be a big debate. Elective dissection versus watch and wait. The verdict is in. Elective neck dissection wins.
Meaning we clean out the lymph nodes, levels I, 2, and 3, even if they look normal.
Yes. Because the risk of occult or hidden metastases of microscopic cells the scans missed is roughly 20 to 30%.
That's high.
It is. Removing them early leads to significantly better survival than waiting for them to grow big enough to feel.
When in doubt, take them out.
In oral cancer, yes, that's the rule now.
Okay, the tumor is out. The neck is cleaned. But now poor Mr. Gupta has a hole in his tongue and maybe a missing piece of jaw. Section 6, putting Humpty together. Again, reconstruction.
This is where the artistry comes in. The goal is form and function. We need him to look normal, but he also needs to speak, swallow, and keep food in his mouth.
We have a reconstruction ladder, but let's talk about the Ferraris of reconstruction. The free flaps.
A free flap means taking tissue from elsewhere in the body, skin, muscle, bone, detaching it completely, blood supply and all, and replanting it in the neck by sewing the tiny blood vessels together under a microscope.
Let's talk soft tissue first. We have 2 main workhorses, the wrist and the thigh.
The radial forearm free flap, RFFF, comes from the wrist. It is thin, pliable skin, like tissue paper.
So where do you use it?
Places where you don't want bulk. If I remove the lining of your cheek or the floor of your mouth, I want a thin patch. If I put a thick slab of meat there, you'll constantly bite it.
But what if you cut out half the tongue? If you put a thin wrist patch there, the tongue is too small. It can't reach the roof of the mouth.
Exactly. And you can't swallow or talk if your tongue can't touch your palate. That contact is how you push food down. You need volume. You need the plug.
Enter the ALT.
The anterolateral thigh flap. It comes from the leg. It has skin, fat, and muscle. It is bulky.
Psi for tongue.
Phi for tongue. You sculpt it into a mound so it acts as a plug against the palate. Function first.
Now, the bone. If we did that segmental resection and took a chunk of jaw.
The gold standard here is the fibula-free flap.
The lower leg bone. Why that one?
It is perfect. It provides up to 25 centimeters of straight, strong bone. We take the bone out of the leg, cut it into segments to match the curve of the jaw, and plate it in.
And the coolest part, you can put dental implants into it.
You can. You are literally building a new jaw from a leg bone that can chew a steak. That is the holy grail of reconstruction.
I want to geek out for a second on the technology, VSP, virtual surgical planning. This feels like sci-fi.
It is becoming standard of care. Before surgery, we get a detailed CT scan. We send the data to engineers. They 3D model the tumor, the jaw, and the patient's leg bone on a computer.
And they plan the cuts on the computer.
Down to the millimeter. Then they 3D print plastic cutting guides jigs that we sterilize and take into the OR. I clip the jig onto the jaw and clip another jig onto the leg bone.
And you just put your saw in the slot?
It guides the saw blade at the exact angle planned. So when I bring that piece of leg bone up to the neck, it fits into the defect like a perfect puzzle piece.
Measure twice, cut once on steroids.
It saves hours of operative time, and the aesthetic result is vastly superior because the symmetry is perfect.
Amazing. Okay, surgery is done, reconstruction is done, but are we finished? Section 7, the aftermath, adjuvant therapy.
This is the cleanup. When is surgery not enough?
We have clear criteria for who needs extra radiation or chemoradiation.
There are major and minor criteria. The major ones are the deal breakers. If you have one of these, you're getting more treatment.
Okay, major number 1, ENE.
Extranodal extension. We talked about this. If the pathology report says ENE positive, that patient needs chemoradiation. Radiation alone is not enough.
Major number 2, positive margins.
If the microscope shows cancer cells right at the edge of what you cut out, you failed to clear it.
You left some behind.
You left some behind. You need to blast that area with chemorad to kill the stragglers.
So ENE or positive margins equals the double hit chemo plus radiation. What about the minor stuff?
Things like perineural invasion, PNI, lymphovascular invasion, LVI, or just a really big tumor, T3, T4 with clean margins. These patients usually get radiation alone. We spare them the chemotoxicity if we can.
Before we wrap up, just a quick nod to immunotherapy. We see ads for Keytruda, pembrolizumab everywhere. Where does that fit in?
Currently, for oral cancer, it's mostly for the recurrent metastatic setting.
So not up front.
Not up front. If the cancer comes back and we can't operate, or if it spreads to the lungs, we use these PD-1 inhibitors. It basically unmasks the cancer cells so the patient's own immune system can attack them. It's not first line yet for curable disease, but trials are ongoing.
All right, we have covered a massive amount of ground. Let's bring it all home with a summary and key takeaways. Let's review our ready reckoner for the listeners.
Let's do it.
Risk factors.
Tobacco plus alcohol is the classic Western synergy. But don't forget betel quid causing cheek cancer in South Asia. And remember, HPV is rare in the oral cavity compared to the throat.
Staging updates.
DOI, depth of invasion, is the new ruler for T-stage. Don't look at the surface, look at the roots. And ENE is the end-stage killer.
Surgery rules.
1 centimeter margins. And do the elective neck dissection. Take the nodes out early, it saves lives.
Reconstruction choices.
Wrist, RFFF for thin patches.
Yep.
Thigh, ALT for tongue bulk. Fibula for jawbone. Form follows function.
Okay, let's do one final fictional case study. This is the exam question to see if you are listening.
Hit me.
A patient presents with a 3-centimeter tumor on the lateral border of the tongue. The biopsy shows SCC. The MRI reports the depth of invasion is 11 millimeter. There is one palpable node in the neck.
Okay, let's process.
T stage.
The size is 3 centimeter, which sounds like T2, right? 2 to 4 centimeter.
Right.
DOT. The DOI is 11 millimeter. The cutoff for upstaging is 10 millimeter.
Yeah.
Because it's deeper than 10 millimeter, it jumps to T3.
So it's a T3, not a T2.
Correct. It's a T3. One palpable node, likely N1, unless pathology later shows ENE, or if it's bigger than 3 centimeter.
Treatment plan.
Primary surgery. Wide local excision of the tongue, probably a hemicosectomy, plus a neck dissection of levels I through 3.
Reconstruction.
It's a tongue defect, likely substantial if you take a proper margin. You need bulk for speech and swallow. I'd argue for an ALT flap from the thigh.
Adjuvant therapy.
The T3 stage is a risk factor, so likely post-op radiation.
And what if that node comes back ENE positive?
Then you add chemo. You have to.
Boom! You just passed the boards.
I hope so.
We are going to leave you with one final provocative thought. We spent 40 minutes talking about TNM staging. We talked about millimeters of invasion. But the chapter mentions genetic profiling.
It does. We know about P53 mutations, which are present in something like 83% of cases, and CDKN2 set. We are mapping the genome of these tumors.
But the text says, and I'm quoting here, current treatment is not influenced by it yet.
That is the frustration and the hope. Right now, we treat based on how big the tumor is, anatomy, geometry.
Right.
We treat a T3 tumor the same way whether it has a P53 mutation or not. We are on the verge of moving toward a world where we treat oral cancer based on its DNA, its biology, rather than just its size.
So are we going to see a day where we don't cut the jaw, but we target the gene?
That is the dream. We aren't there yet. Not even close for most patients, but that is where the research is heading.
Something to mull over. Listeners, thank you for joining us on this deep dive into Baily and Love, Chapter 53.
Yeah, thanks for sticking with us.
Do yourself a favor, open the book, look at the flap diagrams, and solidify what you heard today.
And good luck with your studies. Keep diving deep.
Hey there.
See you next time.